A very good morning to everyone. Today the topic for discussion will be anatomic considerations in endodontic treatment. So coming to introduction, so there will be always a variation in the external morphology of the teeth that varies from every person to person, but the internal morphology of the crown and root also possesses large amount of variation. So there is going to be a change in the pulp canal anatomy which occurs due to difference in age, and there is going to be changes which are going to occur due to disease and trauma. So for the success of an endodontic therapy, the knowledge of the pulp canal is very important, and it is essential to have a good knowledge about the normal configuration of the pulp cavity and the variations that are commonly encountered. So coming to the pulp cavity is a central cavity within the tooth, and it is entirely enclosed by the dentin except at the apical foramen. So the pulp cavity generally is going to be divided into the coronal portion and into the radicular portion. The coronal portion is also termed as the pulp chamber, and the radicular portion is termed as the root canal. So coming to the pulp chamber in anterior teeth, the pulp chamber is going to gradually merge into the root canal, and the division usually between the pulp chamber and the root canal is not visibly distinct. And in case of multiple rooted teeth, the pulp cavity is going to consist of pulp chamber, and it has more than one root canal. So so there is a distinct pulp chamber, and there is going to be a distinct division into the root canals. So the roof of the pulp chamber is going to consist of dentin, and which is going to cover the pulp chamber occlusally or incisively. The pulp horn is nothing but the accentuation of the roof of the pulp chamber under a cusp or a developmental lobe. So coming to the floor, it is nothing but a parallel surface which is going to be consisting of dentin, and it is going to bound the pulp chamber near the cervical region, and it is particularly the dentin which is going to form the furcation area. And the canal orifice is nothing but the opening in the floor of the pulp chamber which is going to root into the root canal. It's going to lead into the root canal. So the canal orifices are not separate structure, but they are continuous with the pulp chamber and the root canal. So the walls of the pulp chamber are going to derive the name according to the corresponding wall of the tooth structure. The angles of the pulp chamber are going to derive the name from the walls forming the angle. So these are the major anatomic components of the root canal system: the pulp chamber, the root canal system, the pulp horn, the root canal orifice, the furcation canal, and the lateral canals. So coming to the root canals, they are going to be the portion which is starting from the pulp cavity from the canal orifice to the apical foramen, and it is going to be divided into three sections, namely the coronal portion, the middle third, and the apical one third. The accessory or the lateral canals is nothing but the lateral branching of the main canals which is occurring in the apical third or in the furcation region. The apical foramen is the aperture at or near the apex of the root through which the blood vessels and the nerves are going to enter or leave the cavity. So this is the representation of the apical foramen. So the accessory foramen is nothing but the openings of the accessory of the lateral canals in the root surface. So either a constriction or curvature is present near the apex. The curvature may be straight with minimal apical curvature, or there may be a gradual curvature with a straight apical ending, or there can be a gradual curvature of the entire canal or a sharp curvature of the canal near the apex. So the success in negotiating a curved canal is going to depend on the degree of the curvature, the size and the constriction of the root canal, the flexibility of the instrument blade, and the skill of the operator. In most cases, the canals are going to correspond to the number of roots, but a root may have more than one root canal. So the classification present for root canals can be, which are vertusi, veins, and classification based on the canal cross section. First, moving on to vertuses classification, wherein you're going to see a single canal that extends from the pulp chamber to the apex. In type 2, there are two separate canals that leave the pulp chamber and join the short of the apex to form one canal. Type 3 is one canal is going to leave the pulp chamber. It's going to divide into two and then merge into a single canal, and as they exit. In case of type 4, there is two distinct canals from the pulp chamber. Type 5 is one canal is going to leave the pulp chamber, and it's going to divide short of the apex into two distinct canals with separate foramen. And in type 6, there are two separate canals which leave the pulp chamber, merge in the body of the root, and re-divide short of the apex to exit as two distinct canals. Type 7, a canal is going to leave the pulp chamber, it's going to divide and then rejoin the body, and then final divide into two distinct canals short of the apex. So in type 8, there are three distinct canals that extend from the pulp chamber to the apex. So this is nothing but a representation of vertices classification. Now moving on to veins classification, there is going to be type 1 wherein you have a single canal from the pulp chamber to the apex. Type 2, two canals are going to leave the chamber and they are going to merge to form a single canal shut at the apex. Type 3, two separate and distinct canals from the chamber to the apex. Type 4, one canal is going to leave the chamber and it's going to divide into two separate or distinct canals. This is the veins classification. Now, based on the cross section, you can classify the canals as round or circular, oval, long oval, flattened, which is a ribbon-shaped canals, or irregular. Now moving on to isthmus. Isthmus is nothing but a narrow ribbon-shaped communication between the canals that are going to consist of pulp or pulpally derived tissue. So all the isthmus must be found and they must be completely obturated because they can act as bacterial reservoirs. Kim was the one who divided these canals isthmus into the following categories: type 1 wherein you have faint communication between the canals; type 2 complete isthmus with definitive communication between the canals; type 3 a complete but very short isthmus between the canals; type 4 wherein you're gonna have a complete isthmus between three or more canals; type 5 two or three canal openings without visible communication. So this is the representation of the isthmus classification. And in apical foramen is nothing but in case of young teeth, it's incompletely developed teeth, it is usually funnel shaped, whereas as the root develops, it's going to become narrower. The inner surface of the root apex is going to be lined by cementum up to a short distance into the root canal, and the CDJ is a very important anatomical landmark because at this particular CDJ, the root canal treatment or the filling material should come to an end. And the apical foramen is not always the most constricted portion, but it is more likely to be constricted in most cases. The apical foramen is also not located in the center. It may exist in the labial, mesial, distal, or lingual surface of the root, but uh, it's usually more prone to be eccentrically placed. And moving on to the lateral canals or accessory canals, they have been found with enough regularity to prove they are a very integral part, and the periodontal vessels are going to curve around the Hertwig's epithelial root sheet around the developing tooth, which are going to be responsible for the formation of lateral canals or accessory canals during calcification. They are most commonly seen in the apical third of the root, which explains their high incidence there. The reported incidence of lateral canals are 27.4 to 4 to 35.5%. To conclude, together with diagnosis and treatment planning, the knowledge of common root canal morphology and the frequent variation is a very important requirement for endodontic success. Although these morphologic variations are going to occur, the clinical experience are going to bring a proper identification of the changes from the general pattern. So the study of pulp cavity morphology is a very important undertaking. Thank you.